This week's comment questions comes from a viewer who asks, how to avoid perforation when removing a separated instrument, and on which surface of the removing tool should be placed. So that's a good question. It's a common question, obviously, when it comes to the idea of separated instrument or removing separated or broken instruments. There's always a lot of interest in finding these out, and part of the reason is because the instruments, especially night-eye instruments, have a higher likelihood of separation. In many places around the world, people tend to overuse these instruments until they end up separating. We'll talk about that a little bit, but that's important because I always talk about the fact that what's most important is that we should avoid instrument separation, and there are proper protocols that we can take in terms of proper instrument etiquette inside the root canal, certainly by not pushing onto instrument beyond its yield limit, and that's the point of resistance, and also by making sure that you change and remove and discard your instruments as much as possible. Clearly, instruments are designed to be used only once as per manufacturer to reduce the odds of cyclic fatigue. That is the reason why these instruments break. But I can understand around the world and the cost of these instruments and compensation for root canal therapy around the world not being as high. Many people have to use them. I've heard in some places around the world, people essentially use the instruments until they break, which I think is certainly not nice to any patient who ends up being that very last guy we find out that found out that the instrument was already too old. The problem with night-eye instruments is the fact that the cyclic fatigue that builds up in these files is insidious, so you cannot see it, and therefore removal and discarding the instruments is very important on a timely basis before they are too old, because you cannot see the fact that they've had cyclic fatigue. But anyway, I'm sure a lot of you guys have probably heard about that before. So let's get back to the point of, if they break, what do we do and how do we remove them? I think the most logical thing to do would be, clearly, if you're a general dentist, then to send to a specialist, because they have the right tools for removal of these instruments. And the main and most important tools here is the microscope, and then the use of some type of a cavitation and kind of vibration tool, which would be primarily your ultrasonic used with water, so that it could essentially kind of transfer this power of ultrasonics into the instrument and then wash it out. When it comes to the microscope, therefore, the most important part of the decision to remove the instrument or not is its visibility. I find that many times when people and gurus out there talk about instrument removal, they kind of fail to really talk about these main factors here. The fact that an instrument that you cannot see from looking at the top with the microscope is going to be very difficult and unpredictable to remove. I'm here to tell you that most of the cases we end up seeing on the internet presented at the podium are cases in which the instrument was managed to be removed and not the one that caused the problem. And I think that's one of those problems that ends up being kind of shoved under the carpet, where in this world of just kind of showing the cases that succeed and do well, people end up getting the false impression that almost every instrument can be removed and under any circumstances. And I think it discards the risks that are involved, such as the question that Jahama asks, is that you could potentially perforate and weaken the tooth dramatically while trying to remove these broken instruments. So you have to make a certain calculation as to what is the most important thing here. Is it just to remove the instrument, or is it to have a long and good prognosis for the tooth? And I tell you that the real world answer to that is that you want to focus on what's the best from the outcome of the tooth, rather than get focused on just removing the instrument. You can certainly remove the instrument if you remove the whole tooth itself, but that's not the goal of endodontics. We want to save the tooth. And many of the studies have shown now that the fact that a broken instrument is present is not itself a kind of a recipe for the tooth not working or an infection persisting. Many factors come into play as to a decision for removal of the instrument. As I mentioned, number one in my book is visibility. Can I see the instrument or not? But also the instrument design. How much chip space is there? Because if the instrument design of the broken instrument was more triangular, you have more room to bypass it. If your instrument design was very, very thick and had little space as a chip space, your instruments might not have easy time bypassing it. And as a result of that, you end up increasing your chances of potentially causing perforations, deviations, and ledging around the instrument. And that instrument not only does not come out, but now at this point, after having perforated the tooth from your attempt to remove it, you've actually caused more harm. Let's take a quick look here to show you what I'm talking about here. Let's say on this tooth, and you are trying to kind of access to get in, and let's say you've accessed and you've gone in the tooth already, and so now an instrument has been, unfortunately, let's say, been broken. If the instrument is broken here, That is a lot easier to get out than once the instrument is past the visibility side. And by the way, in order to increase your chances of being able to see what you're doing, what you want to do is to give yourself straight line access by removing these areas so that you can see the instrument much better. So you're going to go into that space, and then you want to create a little platform. So you want to go a little bit beyond the sides of the tooth so that you can then be able to start to dig a little bit on the outside, a little bit on the inside of this area, and be able to create a part of the instrument that you can then hopefully isolate by drilling a little bit using ultrasonic on the sides of it. So now you have something that you can grab the instrument with. And as we know, there's many different ways. You can put an ultrasonic at low power on the side of the instrument and then let it vibrate out if it's been loosely kind of launched. Or if you can see enough of it, you can have one of the loop techniques using either the Tarucci's loop or the Dennis Kohler's cowboy loop to go around the instrument, grab it and bring it out. But again, everything relies on the fact that you can see it. If you can't see it, the concept that you can go in there and easily remove a broken instrument that is broken right here at this step, this ledge, by merely just putting an instrument and trying to, let's say, by giving yourself a little access here, like that. You know, this is not so easy because your instruments are going to want to go further down, and you will easily cause a ledge here, which if you continue, then will cause a perforation. And now, not only you haven't solved the problem of the instrument removal, but you now have a whole separate problem here, which is the problem of potential for infection right around this area. So it's important that you don't lose the forest for the trees. I'm here to tell you that this whole, all of the pictures and stuff like that you see on social media about the instrument removal is a little bit overrated. I think we need to come up with a question of a ratio of what percentage of these are being removed and what percentage of them are actually not being removed, or iatrogenic problems are happening as a result of an attempt to remove them, in order to be able to make a better decision as to what should be removed. My general rule is that if the broken instrument is beyond an area where I can see under my microscope, I'm not going to give it too much time. I will try to give it about 15 minutes or so with my thin ultrasonic tip, if you will, very gently to go in there, see if I can just vibrate it out. And then I may use a thin, stiff file like a size 6 or an 8 and see if I can bypass it. But I will not use a whole lot of chelating agents around that area, because that increases your chance of potentially causing a perforation by just not really realizing that you're pushing hard and you're actually drilling into dentin as opposed to be able to bypass the side of the instrument. I know that I'm not being quite as helpful as you wish I could be by just giving you a magic formula to remove that instrument, because I'm here to tell you that the real answer to this question is that there is no magic formula. That anyone who tells you otherwise is probably either trying to sell you something or giving you a fantasy of what they can do that other people can't do. What we need to do is we need to first triage the case as to separations that are above the area where you can see or areas where you cannot see it. If I can't see it, I give myself only 15 minutes to try to bypass it or lightly vibrate it. And if that doesn't happen, then I will obturate. Now, another couple of factors that are also very important is what is the status of the tooth before the separation happened? Was the tooth vital? Was it necrotic? And if it was necrotic, is there a substantial amount of space beyond the file that is still infected? Is there a lesion or is there not a lesion? Because don't forget, as long as the patients are not symptomatic, you always have the luxury of the ability to monitor them, place a bonding restoration in the axis preparation, have them come back in a few months, and if they have no symptoms and there's no lesion and there's no expansion of the lesion, many of these cases do well. But if you already do have a lesion and the lesion is not healed after a few months, worse yet, it's increasing in size and getting worse, then in these cases, apical surgery would be the best and most predictable option, as opposed to spend a lot of time inside the tooth, hollow out the tooth significantly, which will weaken it and then cause more chances of cracks and fractures at the cervical level, where that's the most important kind of dentin that we want to preserve. Whereas chopping off the apex of the tooth the last couple of millimeters and putting a plug in it is not going to weaken the tooth to the same extent. So keep an eye, don't lose the forest for the trees by focusing just single-handedly on removing the instrument. Focus on trying to create the best and the longest lasting case scenario for your patients. And with that, I hope this was a little bit helpful to you in order to be able to just triage a case where you have a separated instrument. If you're a general dentist, make sure you try to refer it out to somebody who has a microscope and ultrasonic and has experience in removing them. And of course, surgical experience is also very helpful because it gives you the ability to manage these cases if the conventional attempted removal does not work. But many of these cases, if you've done the right job of triaging the case, where if it's a larger size instrument that has been broken, it also means that the canal has already been cleaned out enough when it broke. When it broke, did it break at the beginning part of the procedure or towards the end of the procedure? All of these factors are important in terms of how much cleaning was done before the instrument broke. The fact that a broken instrument is only present in the tooth in itself is not deterministic in the outcome of the patient. It doesn't sentence the patient to a negative outcome. Anyway, hope this was helpful. I'll come back in other videos. I'll probably show you a little bit more on this. See you guys in the next video.